All right. Well, I will bring us to our start. It is lovely to be together this Thursday before Thanksgiving. Please continue to grab food and coffee and find a seat. Welcome to those of us who are also joining by Zoom. So just a few brief announcements before I announce our presenters for today. The next Grand Rounds is December 4th, which will be on Delirium by Dr. Joe Hippensteel. Next Journal Club is December 11th on Zoom, Dr. Garcia and maybe someone else. Thank you, Gretchen. Fabulous. Dr. Orris. I was like, I don't think it's Dr. Farrow again. So we will have evaluations available in person and online afterwards. We welcome your feedback. Please also feel free to use the chat if you're on Zoom, and then we will have Q&A afterwards. But without further ado, we're really excited to have Dr. Peng and Michael Klein do a combined presentation. Thank you for your work in preparing for us. So today's presentation title is noted here, but briefly, Dr. Mandy Peng is an assistant professor of geriatric medicine here at CU Anschutz and medical director of the CU Medicine Geriatrics Clinic at Kavod. She completed her undergraduate studies at UC Berkeley, medical school at NYU, and residency and fellowship in internal medicine and geriatrics here at CU Anschutz. She's interested in improving access to patient-centered multidisciplinary geriatric care for underserved older adults with multimorbidities who face barriers to care. And some of her work was presented at this past Saturday's Healing the Divide Health Equity Conference, which was great. Michael Klein has over 35 years of experience managing long-term care organizations. His tenure in his current role as president and CEO of Kavod Senior Life began in 2010. Under his leadership, Kavod has thrived as an affordable senior housing organization offering senior and assisted living to over 400 older adults on the Kavod campus each year, as well as life-enriched programs to an additional 1,500 older adult individuals in the surrounding community. Michael has previously served on the national board of the Association of Jewish Aging Services and on the state board of Leading Age Colorado. He resides in Denver with his wife, Wendy, who is a music teacher and enjoys spending time with his two grandchildren who live close by. So without further ado, thank you so much.
Thank you very much. We're going to figure this out in a second.
Okay, I just need this.
All right.
Okay.
Anyway, I'm delighted to be here. I want to present a model that we're doing with CU Medicine, which is pretty innovative, and I think there's a lot to be learned from it. I'm going to do more a micro version of what we do at Kavod, and Dr. Peng will expand a little larger into the greater community. With us today, I have Mandy Bertram, who's our Director of Wellness at Kavod. So if I screw up, she'll be the first one to let me know. But anyway, so we're going to cover, kind of Kavod Senior Life, the programming and partnerships, and then Dr. Peng will get into more the CU Geriatric Clinic. So with that, let's go into the first slide. So within senior housing, I'm not sure how much people know, but it's kind of a continuum. And you have everything from independent senior living through skilled nursing. We really focus on the independent part and on the assisted living part. So within the independent living part, we have 370 residents that live at Kavod. We're subsidized housing. I'll talk a little bit more about that as we progress. And we also do assisted living. Assisted living, for the most part, it's private pay. At Kavod, we're both private pay and we do Medicaid, which is kind of atypical within the industry. And we're going to get further into, as you go along the continuum, independent living is pretty much older adults living on their own with some support services, all the way through skilled nursing, which is far more intense, a lot more regulation, a lot more RNs, LPNs, and heavy duty support there. So we'll go to the next slide. What's interesting about the senior population is that really almost 65% are in the community. They're living at home, they have their own lives, they really don't need a lot of services. I'm going to really talk about at the far end, when you get to the end there, you have 3% that are in subsidized housing, 2% in assisted living, and 2% in nursing. So very small percentage ever go into nursing homes. Most older adults are able to be served within the community. Within the world we live in, everything is initials and acronyms. So of course, we get funded through HUD, which is the Housing and Urban Development. We're Section 202. What 202 means is that in order to live within a HUD building, you have to be 62 years or older, and your income has to be less than 50% of the area mean income. And within Section 2 housing throughout the country, we're serving there are about 400,000 older adults that are served within HUD. Again, what's really interesting about what we do at Kavod is you can see the average person 62 and older probably on a yearly basis has about almost $40,000 of income. At Kavod, the average person living at Kavod, it's more like $15,000 a year, which is what they have available to them. And when you break that down, it's roughly, you can see $1,250 is kind of the monthly amount they have to spend. And we are very affordable. The average rent at Kavod is under $400. But when you get right down to it, the people living at Kavod, they really have about $500 a month to live on. And that includes medical, transportation, food costs. So a very low income population we're serving. Within most assisted livings and IL, this is more national information. You can see the basic, it's the activities of daily living. The biggest needs are medication, bathing, dressing, toileting. And then on the right, just some of the basic diagnoses that you'll see within the building. And this is pretty typical of what we see here at Kavod. So just to back up a little bit, we've been around since 1971. And Kavod is kind of an unusual name. And do people know where Kavod comes from? Beyond Mandy. All right, so Kavod comes from the fifth commandment. And the commandment is you should honor your mother and father. And Kavod is the word for honor and respect. And so it's something we take very seriously. We do have some issues during COVID. Everyone thought that COVID, confused us with COVID, and we're not. We're much different than that. And actually, through COVID, with the 400 residents that we served, we really only had one death over the couple of years, which is really a testament to the staff and what we had to do to support them during that. Again, some basic information, $15,000 is the annual income. As you can probably guess, the majority of the people at Kavod are female. The average age is almost 80 years old. What's kind of unusual about Kavod is that we have a very large population from the former Soviet Union. So what that means in providing care, not only do we have to, we're dealing with language issues, and we have many, many staff that speak both Russian and English, which really helps what we do. And because we are at such a low income point for people, there's a very large demand to move into Kavod. So we have almost a 2-year waiting list for people who want to come in. And the next one. Just a couple of pictures. We're located in Cherry Creek. We were in Cherry Creek before Cherry Creek was Cherry Creek. So we're very fortunate to be where we're located. It's a great property, access to transportation, to the mall, to restaurants, all that good stuff. And this is really the model of what we do at Kavod. And I'm going to start first with the care coordination. So Mandy oversees a team of 4 care coordinators, and really anyone in the building, whether it's accessing medical services, whether it's getting Social Security, whether there are family issues, the care coordinators, that's really their focus. So 4 care coordinators to 400 people, it's still not a great ratio, but it's there, and it helps support the people that live at Kavod. For the independent living people, we provide 6 meals a week, all kinds of special diets for those people. In the assisted living, we're doing 3 meals a day. Life enrichment, lots of programs and activities that we're doing there. Every day there are 5 or 6 things going on, everything from chair yoga to art classes, music classes, gardening, you name it, we probably provided at Kavod. Resident support. We have outdoor gardens with raised flower beds, so if you're in a wheelchair walker, you could access them. We have chaplaincy. We're Jewishly hosted, so we have a rabbi on staff, but for the Christian residents, we have the mustard seed congregation on Sundays to serve that population. Adaptive technology, we've done a lot with that. We have about a dozen apartments with, if you have a tablet, and let's say you're in a wheelchair, if someone knocks on your door, you can use the tablet to open up the door, to control the lights, to control the thermostat. It's another way that we believe that we allow people to age in place without having to leave Kavod prematurely. We do community outreach, which really isn't part of this, but we do an annual aging conference, and Dr. Levy was one of our leaders last year in that, which was wonderful. And we have a Kavod on the Road program. We take a lot of the programs we do, we take them out into the community. What really, I think, makes things special at Kavod, and really it's thanks to the relationship we have with CU Medicine, is we have a geriatric clinic embedded within our building, and that is so, so important. When I first came to Kavod, we were always having residents at Kavod where there'd be a medical issue, and you call 911, they would come, they would take people to the hospital. Who knows what they did there? They'd send them back. The residents really weren't sure what was done there. We weren't sure what was done there. And a week or 2 later, they were back in the hospital again. By having the clinic in the building, and we have almost, I think we have 85 or 86 residents that partake of it, there's medical care 3 days a week, and it really helps. So if you look at our population, and if you're close to 90, or in 80s or 90s, you're frail, it's difficult. A lot of the residents don't drive. It's difficult to get out into the outer world to see a doctor. It's so wonderful having the physicians right in the building. So again, we are so happy with our relationship. Early on, we were trying to get hospitals involved, and we would talk to hospitals and we'd say, hey, we'd love you to come to Kavod. And they'd say, well, what percentage of your people are private pay? And we'd say 1%, and they'd say, well, thanks, we're not interested. So again, one of the things you're dealing with older adults is, are they private pay? What are their resources? Our residents don't have those resources. So it's been so nice having the relationship. Also, within our building, We have Legacy Rehab, and that's a partnership we've had for over a dozen years. We have 5 days a week. We have PTs, OTs, and speech therapists in the building. Same concept. If someone falls, if they need help, we don't have to send them out into the community to a clinic. They can go right into our rehab space. The therapist will go into their apartments. It really helps with what we do. And then we'll get into partnerships a little more in a second. Here's our health and wellness team. You can see Mandy is there, the 4 social workers. We have a scheduler, and we do a lot of surveys to see, how are we doing? What are the results? Are we making an impact? And you can see, like, without going through every one, but the top one, addressed my health and well-being needs. Over 90% of the people, either strongly or agree or strongly agree. It's a very, we really listen to what the residents want. We try to give them the services they need. And I think for the most part, they're pretty happy being at Kavod. Again, in order to take this low-income population and support them, we've developed a lot of different partnerships. So we talked about, University of Colorado Medicine. The dental school is looking to come into our building. That will happen in January. That's another way that we can provide better care for them. Home care agencies, Dr. Aaron Greenstein, who's a geriatric psychiatrist, is a resource to us. All kinds of different services come in. Even, you can see at the very bottom, we have about 50 or 60 residents that have dogs and cats. And if you think about it, if you're low income, that costs money for vet care. And we were able to get a grant where we have a veterinarian come into the building and can provide basic free vet services. So we look at the whole individual and see what we can do to support them. This is just one study, but again, it gets to what we've been talking about. Nearly 1/4 of older adults, 60 or older, that report being in poor health. Within 3 years, they've been able to get backed up to where they should. And that's where our focus has been. When people move into Kavod, in general, if they're coming in from the community, a lot of times a spouse has passed away. They're living in their house by themselves. They're isolated. They're not getting into the community. When they come into Kavod, we provide this wraparound service to really allow them to age in place, to have neighbors, to have support services. And then as far as things that we try to measure, in general, the average person in independent living stays within an independent living for about 5 years. At Kavod, it's 7 years. In the assisted living, 2.2 years. At Kavod, it's 3.3. And I really want to focus on that little nursing home thing. So when I first started being involved in senior care, I was in Minnesota, and the average person in our nursing home lived in the nursing home 7 years. That was way back in the day. When I left 15 years ago, it was down to 7 months. And now you can see in the industry, it's 5 months. Nursing homes, to me, and I'm not sure where you all fit in, they're almost dinosaurs. The people are moving away from nursing homes. They're looking for how we can support people in the community, bringing in services, what we do at Kavod, what we do in assisted living. Nursing homes have really become places you go for short-term rehab, or if you have really complex medical care, you end up in a nursing home. But you can see the average length in a nursing home is really, really short. And then as far as when we try to measure what we're doing, at Kavod, like I mentioned, the resident pays a little under $400. We get subsidized by HUD. So it's about $2,100 is what we get a month. And in the assisted living, it's closer to $4,000. What we're happy about is if we can keep people in our buildings, if we can keep them out of nursing homes, to go from $2,000 a month to $10,000 a month, which is kind of what an average nursing home costs, that's like $8,000 a month. It's almost $100,000 a year. And if you look at what we do by keeping people at Kavod and giving them a really good life, if you took just 50 people at Kavod and you kept them out of a nursing home for a year, that's almost $5 million. So I think what we do has a major impact when you look at how everything gets funded. And one thing that we're here to pitch a little bit is we really like doing research and we like being a lab for the community. And Mandy and our team we're always looking at what can we do to work with academics, to work with researchers, to find better ways to allow people to age in place. So over here, Sexy Walker, there was a group that wants to look at walkers. People use walkers all the time, and typically you get the tennis balls on them, and they're awkward. There are some really sophisticated walkers out there that you can sit, you can put things into. So we did some study with them to look at better designing walkers. Uber app, again, for a lot of seniors, getting out and using an Uber app is really difficult. It's even for me difficult. So the goal was we had about, I'm not sure, Mandy, like a dozen residents. The goal was to use an Uber app. The goal was to get out to an ice cream store to get an ice cream and get back. And by doing that, they were trying to figure out what buttons to use, how to do it, how to make it simple. So that's one example. Peng was a watch that a small developer was using, kind of like an Apple Watch at a lower price point. That was both a watch, it did some medical measurements, it was also a phone. We did that for a couple months. And we're always looking for different groups to partner with. So at the far end, we just got money for Capable. And do people know about Capable at all? See a head nod, maybe. So Capable, again, is this wonderful program, and Dr. Peng is going to talk more about it, developed at Johns Hopkins University. They were concerned that people being discharged from the hospital going home were coming back into the hospital. And it's like, what can we do to allow people to age in place and not come back prematurely? Capable uses an RN, it's a team of an RN, an OT, and a building person who can help put in grab bars and stuff like that. We will at Kavod, we're going to do it with 30 residents. We'll do it for a year there. Then we're going to do it in the community. The goal, again, is to go in, bring in some integrated care, help people stay in place, not have to, leave us to go into nursing home. And Mandy will talk more about that. And again, one of the things, we like doing different things. So
Ryan is a companion robot that can play games, hold conversation, and even do yoga.
Find a comfortable seat.
Yes, I got my seat.
Sit up nice and tall.
Mary can't even fathom how Ryan works.
Now return to breathing in through your nose.
That mechanical stuff, that's not me at all.
Thankfully, there is someone who understands.
Yeah, so of course we know. We have designed it.
Mohammed Mahour is the brains behind Ryan.
As you can see, Ryan can recognize my facial expressions. It is great to hear from you again. What is new with you today? Can you tell me a joke, Ryan?
He's been perfecting the social robot for 16 years on the DU campus.
All right, so that's just another example where we work with researchers. This is the third iteration of Ryan. When he first came in, he was kind of scary. He had no real face and intimidated all our residents. They've been working on him. Again, those are the kind of things we like to do at Kavod. We like to work with researchers see what we can do, what, take their research and take it into a practical place and see where we go with it.
Ryan is.
That's Ryan again. And now I'm going to turn it over to Dr. Peng, and you can control your own stuff. Thanks.
Thanks.
And I can answer questions. We'll have time afterwards for questions.
Yeah, we should have plenty of time. Okay, so we're going to start with a case. This is Bob and Judy. I think some of you recently took care of him in the hospital. He is 97, the cutest guy. He was admitted recently for bullous pemphigoid, which is a blistering skin problem, and orthostatic hypotension and adrenal insufficiency. So coming back from the hospital in subacute rehab after 2 months, he is deconditioned and can only walk 20 feet, which is really below what he used to do. So for this, for the bullous pemphigoid, he needs help applying topical steroids on his legs 2 times a day. We can only get home health nurse wound care 3 times a week, and he gets PT 2 times a week and kind of needs more assistance with ADLs. And Judy, they've been married for 73 years. She's on chronic oxygen and can't see very well because of her macular degeneration. And she also gets very anxious, especially when Bob was in the hospital. And so on a short notice, she needs somebody coming in to help her set up medications, just checking on her, and with showers. We're going to go through kind of think about how we piece together all those services for a population like that, for a couple like that. It's a pretty typical example of the people we take care of, and they're in independent living instead of assisted living at Kavod. Okay, this is our clinic. We have 3 providers, Maria Vihar, Dr. Heldreth, and me. We each have 1 full day of clinic there now, which has been really amazing expanding. We have a part-time clinical pharmacist, Dory Hootie, who used to work at Anshu, so she knows a lot of the protocols of, and is really good at learning new things, annual wellness visit, transition of care, and chronic disease management. Since August, we also finally got a social worker. She helps us with both behavioral health and case management, which I think all of them need either one or both kind of all the time. We kind of transitioned the model. So now Katie Wood is our lead nurse. She used to divide her time between our clinic and another clinic and just comes in for clinical work. But now she's really taking on the lead and care coordination. She kind of helps with triaging. So really kind of the glue of the clinic. She knows every patient. So when we see each other's patients, she can help us kind of fill in the background and kind of what they need. And Tammy Dreyer, she's our lovely medical assistant. Before Tammy, we also had a hard time with like a permanent medical assistant. And I think they have to do more. They have to room people. They have to vitals, check in, and then do all the lab stuff afterwards, and then room the next person, kind of all overlapping. So Tammy has been fantastic, and we really run on time on clinic there. And we see both Kavod residents and people from the community. So we see, like Michael mentioned, 86 Kavod residents, which is actually only maybe about a third of our total panel. But I think by experience, I think they're maybe more than half of our total visits. So they just need to be seen a lot more frequently. And I think now with a really solid team where things are really going pretty smoothly, but some of the challenges that's just unique to taking care of a patient population with high needs and limited resources, care coordination, I think within one system under best scenario is difficult. And so at Kavod with transition of care, we don't always know when people are coming back. We can't, trying to get them into clinic. Our frozen spots are usually already full. So take some rearranging and, sometimes even lunch hour because they can't wait another week, especially for discharges like the one Bob had. With assisted living, again, they're only a small percentage of people, but everything needs an order. We are operating with 2 different systems. We don't have access to their PCC. So you can see how sometimes there are a lot of rooms for error and a lot of faxing back and forth and calling back and forth just to make sure everything is staying on the same page. The care coordinators, we'll talk more about them, but they have been absolutely fantastic. So for most of the independent living, we're really relying on home health. So for the subacute needs after discharge and for Medicaid patients, the long-term care ones. Legacy on site, we also try to meet with them quarterly to talk through some cases. They do some home visits. So a lot of times I get more information by meeting with them. They really see how they function kind of in their homes. So, and then additionally, kind of HIPAA, it takes a lot of staff training to make sure we're communicating securely, and then staff training and all of that. Okay, so I don't think this is a surprise to any of us. People who live in subsidized housing, lower income adults have higher prevalence of geriatric conditions, and they're more likely to be hospitalized, and they use nursing home facilities more than general community population. And functional impairment is associated with hospitalization and subacute rehab. And functional impairment and dementia are associated with need for long-term nursing home placements. So I think, like what Michael was saying, to kind of keep people at Kavod longer, I think those are the two things: improving their functional status, if possible, and supporting their needs when they come up is kind of our two goals. So the next two sections, I want to think a little bit about where medical care fit in and what evidence-based interventions are out there to support older adults in subsidized housing. And again, like Michael said, it's 5% of the population total, more than who's in nursing home. And I think, at least within medicine, it's really being left out of conversations. I don't think we have a good idea how to study the population, what they need, and how to take care of them. Okay. So even though the next few slides are going to be on assisted living, I think the tensions and the same issues really apply to the independent side of Kavod as well. A lot of this comes from Dr. Cheryl Zimmerman at UNC. I think Kenny probably knows her well, and Gary too. And, so learning about some of the history of assisted living really kind of put into perspective for me, kind of the tensions that we see in clinical work day in and day out. So assisted living America evolved in the 1980s as an alternative to nursing home care. And its original goal was to provide person-centered care that's responsive to the care of the residents in a home-like environment and really prioritizes resident autonomy, choice, and independence. But in the mid-1990s to 2000s, I think people realized there are a lot of needs and there's a lot of money coming in, and a lot of expansion. But the initial ideals and the way it should be done is kind of being lost in this process. So there are a lot of conversations and concerns about the variability, quality, and standards of care in assisted living. And then again, at the same time, we know people in assisted living, their acuity is really increasing. So how we talk about how people are getting discharged from hospital sooner, so nursing homes are running like a hospital sometimes. The people who are living assisted living, and I would argue independent living at Kavod, is looking like people who otherwise would be in nursing homes in the past. So there's this disconnect between our current system and what the residents now needs. And now it makes sense because it kind of just became this way. It was never designed to do all of that. And there's an earlier study in 2011 on physician perspective on assisted living. And I think we all have a little bit of this discomfort of how much medical care can we expect from assisted living. And with each facility, they all have different resources and different capabilities. So it's all going to vary a lot. So again, Dr. Zimmerman in a paper kind of really laid out all the tensions when we're talking about how to improve assisted living or where we should go from here. The social and medical models of care, we're going to talk more about that. The safety and autonomy, I think in geriatrics, we talk about that almost all the time. financing, so balancing and regulation. So like balancing how much regulations, how much staffing, how much services to provide with accessibility. So again, like Michael said, assisted living are usually private pay, very expensive and increasing in cost. So how do we provide housing in a lower cost and more effective way? The acuity, we need, so 40% of residents have dementia, and in general, it's underdiagnosed and really not focused on. Workforce, so same with nursing homes, there's always shortages. So when we talk about minimum staffing ratios and staff training, sometimes the problem is even just hiring people to work in assisted living. Okay, so the social versus medical models of care, all of us really trained in a medical system, and we're really used to working in a very protocoled, highly regulated environment with enough resources to support all of that. And I think physicians, even like the liberal ones of us, likes kind of the control of being able to dictate how care should happen. So we really see that dichotomy kind of in assisted living, and a lot of times it's this, why can't we just do that type thing? But now I think it's more clear, kind of, why do they have to serve caffeinated coffee at dinner? Doesn't really make sense, but it's a choice. Or so kind of again, and like who should be leadership? I think if you have a medical person in leadership, the protocols and the regulations going to be very different from a multidisciplinary team who has different perspectives on, this is where people live. They're going to do what they want to do. Okay. In 2022, there's this paper on kind of recommendations for what medical and mental health care we should have in assisted living. The list is really long, so that QR code links to the paper, and table 2 is the entire chart. I tried to write some of the ones that have that was rated high importance, so like 8.5 out of 9 with almost unanimous agreement. And staff training, I think, is one that I think we can really focus on, especially dementia care. How do we manage behaviors when they come up? Nursing and related on-site services. So toenail actually wouldn't cross my mind as a top priority, but it really makes a lot of sense because they can't travel, right? Flu shots, PTOT, and some of this like insulin injections and nebulizer treatment. I think sometimes as a clinician, we're like, well, of course they need insulin and have their sugars checked, but not every assisted living place has a skilled nurse who's able to do that. In terms of like coordinating care, even just having medical care or mental health care on site, it wasn't, I think sometimes just not realistic. So having post-visit notes to coordinate is kind of their top recommendation. And having a policy and procedure for behaviors and suicidal ideation. In medicine, again, that's like the safety thing that's top of our mind. We always want to make sure everyone's safe all the time. But what do you do with somebody who might have chronic SI and chronic agitation in a facility? How do we can't just kick everyone out, and what do we do with that? Advanced directives, discussions, and documentation, and then just having, sounds like a given, but having the resident themselves present when they're talking about their care plans. Okay. I think so, just a lot to think about, I think, as we move forward. Okay. Interventions that helps people age in place in affordable housing. So Michael really mentioned the capable. I'm really excited we're able to do that at Kavod. It sounds like it's the first HUD housing in the nation, which is really exciting. So they'll have a team of a nurse, an OT, and a handy person who can help with home modifications. And I think, and the part I really like is they're asking what the patient wants, like what's important to you, what kind of daily activities do you wish you could do, and kind of tailor to those needs. And they get some money for actual home repairs and modifications. So they have like randomized controlled trials studying this, and there is a substantial reduction in their ADL disability scores that was clinically meaningful, and cost saving for Medicare and Medicaid. So in the 22,000s for Medicare, and for Medicaid is, I think, a pretty impressive number. I think even more impressive, I think you guys can see that, it's how the participants feel about the program. So the light blue are the intervention group. More than 80% of the participants feels that the program overall benefit helped them a great deal. So that's really high number. It make their life easier, makes their home safer, keeps them living at home, help them gain confidence, and help with their ability for self-care. Okay, the other successful program is Vermont's SASH. So this one is not focused on just older adults, but they are providing on-site support services and care coordination for adults and individuals with disabilities in affordable housing properties across Vermont. So they do annual health assessments. They have individualized care plans, personal coaching, care coordination with medical practices, and then they have group programs and other services by connecting with local nonprofits and partnerships. So if you notice, Mandy's health and wellness department and the care coordinators really do all of that at Kavod. So what they found was it really does help people age in place. They report improved physical function and improved ability to manage their medications. And I think also very interesting, it helps avoid evictions, just because when issues come up, or they help connect them to care for their physical and mental health issues, or they can address things earlier on before people are getting to the point where they have to be evicted. They didn't see a change in hospital and ED utilizations, but did see a shift from specialty care and acute care settings to primary care offices. Also interesting when we think about what's the goal of like our medical care in a setting like Kavod is, I think in the medical setting, we're always talking about healthcare utilization, how do we keep people out of the hospital, but maybe in assisted living, the people are going to be sicker, and maybe we don't want to be able to provide all the hospital level of care in assisted living. So just kind of what is our goal and what should we design the care model to? Okay, so bringing it back together, just listing again all the programs that Kavod has into those two big categories. I think, Mandy, the programming, I should show you like the whole list and the calendar every month. I think Maria, when she first got there, she's like, well, I want to move in here when I'm older. And having Legacy on site has been amazing. Again, mental health, they have a few options. There's a contracting company to mental health providers, and Courtney now can help with behavioral health. And Dr. Greenstein, who's a psychiatrist, sometimes we have these monthly meetings with all the care coordinators to talk about like people's behavior. How do we manage it? Why are they doing this? And is it dementia? Is it depression? It's always both. And then all the home health companies that have been helpful and supporting people's needs. So we're doing SASH. We're gonna do Capable. Dr. Lam is helping with the guide program with some of the people with dementia in assisted living, who a lot of times actually their family don't come to their appointments with them because they're in touch. They just don't have to show up for appointments because they live there. Meals, they're at our farm who provides like produce so people can get organic produce, podiatry, audiology. Wanted to just point out Dolores on the bottom. When I first got there was a lot of times people with dementia, and I'm kind of like, how are you managing your medications in independent living? And Dolores' name came up all the time. And so I think what she does, sometimes she helps fill pillboxes. She like calls people to remind them to take their medications. I have one lady with dementia, and like really likes to be social, but can't find her way around, and used to get a report of her getting lost, on the bridge and things like that. So Dolores will like come and bring her to the activities, and it's really helping more with her mood and behaviors more than any antidepressant I ever tried to put her on. So a few takeaways: housing-based interventions can meaningfully improve functional status in low-income older adults and help them age in place. Kavod and CU Medicine, we partnered to provide evidence-based interventions and support to low-income older adults, but we need more research to help guide us on how to best provide care in the senior living facility setting. And then average length of stay in AL and IL is much longer than in SNFs, and so we need to talk about the cost-effective and how to coordinate care that balances the social and medical needs of residents with increasing complexity. You want me to do it? You can do yours.
All right, and I'll just wrap it up quickly, and we'll leave time for questions. From our perspective, I guess the biggest thing is how important partnerships are. There are a lot of HUD buildings out there. A lot of them don't have those support services. What allows older adults to age in place, you got to find partnerships, and they're not always easy. You're dealing with a lot of for-profit companies, and they look at Kavod and they're like, we have no interest at all with you. And then we find, Mandy does a great job in finding the ones that will help and work with us. Again, we've talked about it. We love doing partnerships and we love doing research. And for anyone out in this group that would like to do research with us, we'd welcome that opportunity. And again, just a big thank you to CU Medicine that really, they've been the anchor. They've been what has allowed us to do the good work we do. As an aside, Jody Waterhouse is now a member of the Kavod Board of Directors, so we have some direct impact into what we can bring from here to Kavod. So we thank you for being part of us. And I'll leave it there for questions for either one of us. Sure.
Just want to start by saying thanks for the presentation. It was fantastic. I love the model that you're using and that you're implementing. That's really positively improving the health and well-being of our older people in Colorado. My question, I have two really, and they're different, totally different topics. One is, so we know that exercise interventions are accepted, particularly structured exercise interventions, are exceptionally productive in health and well-being of our older individuals. Do you have an exercise physiologist? Do you have structured exercise programs beyond PT and OT, just focused on improving physical capacity?
I'm going to. Luckily, we have Mandy here, so Mandy will share the many exercise programs we do offer at Kavod.
So we just did a cross-sectional analysis of our active and non-active residents in regards to their participation with our wellness programming and fall intervention.
Yeah, Mandy, come on. Yeah, Mandy, come on.
Okay, the microphone.
Oh, go ahead. Just speak.
So it's something that we didn't find it statistically significant in that capacity. So that's something we're looking in further to follow in line. We are going to start a new program that Jody connected us with. It's virtual, but it has the health assessments with it to see that model and see how we can expand that within our wellness programs. But we have a lot of wellness. We have boxing, chair yoga, tai chi, relaxation. So we're really going on the mindfulness because we're seeing a lot of positive interactions with that with meditation. So just pairing them both together. But we are looking to connect the health.
But we do have a lot of exercise programs.
My second question was, I love that you're teaming with HUD, and I wonder in this very, very weird political environment that we're in, is there concern about financial security of HUD? And how are you looking at that if heaven forbid, if something were to happen to HUD funding?
That's a great question. So currently, we look to the House and Senate to kind of put bills together, and they merge and they come up with what they think would be appropriate. Unfortunately, or that's what's going on. The administration, in their infinite wisdom, would like to take all of HUD funding and shift it to the state and say, okay, each state can do whatever they want to do with HUD. And what the White House proposed was, we'll do that and we'll reduce your funding by 40%, which would be catastrophic. That did not go over well. Currently, in Congress, we're looking at flat funding, and we should be okay. Even with flat funding, we should do okay. Kavod has a foundation. We do a lot of fundraising. We do a lot of grant writing. We probably each year bring in about $500,000 in funds from the Weinberg Foundation, Next 50, Jane Rose Phillips. But we are concerned. I think anybody who's if you're getting Medicare funding, Medicaid funding, SNAP funding, HUD funding, we're in a very turbulent time, and it's hard to tell where we're going. So, short answer.
So I think what you all are doing at Kavod is awesome, and I think you've worked really, really hard to build all these partnerships. Clearly, you've taken a lot of time and effort. When I think about the big picture, how awesome would it be for every older adult to have access to this? Clearly, it's a very small community. In an ideal world, how could more people have access to something similar? I know you talked about balancing regulations with doing what's person-centered, but what could an ideal world look like where this would be available more broadly? Or how could it? I don't know.
I think I'm always curious on what is the minimum, most essential services on site that can help coordinate care off-site. They might not need an office physically in the building, but Bloom has been doing a lot of work in a lot of assisted living. And I think really just having, I don't know, Mandy, you probably can speak to this, but coordinating with so many different medical offices, and that might be more challenging than coordinating with one or two offices. So maybe, social work might be more important than really having medical care or having access to mental health, whether that's on site or virtually, or they come in once a month, might be enough. And it just but I think transportation is still going to be one of the challenges. It's still a challenge at Kavod. Sometimes even just picking up medications from down the street, it's hard for antibiotics anyway. So to answer the question.
Yeah, and just to add to that, Mandy talked about Capable. Capable is in 40 different locations throughout the country. There's an effort to try to get Medicare or Medicaid or Medicare Advantage programs to pick up on that. We didn't even talk about PACE. I think PACE is a great program. You have several PACE programs in the state. I think it's going to take a lot of individual groups forming different partnerships and things. I think the money is pretty limited out there, and I'm sure that's just what we struggle with all the time is where you get the funding. So in the ideal world, the president would say we love HUD and we're going to bump it up 20% and we're going to increase Medicare and Medicaid. I don't think we live in that ideal world. So I guess just more partnerships and being creative and trying new approaches.
One more thing was I think just residents getting along and having that social group, sometimes even just getting them out of the house. And I think some residents actually are more high functioning than others, and some people can still drive. So if they can kind of somehow figure out a way to take care of each other too, costly.
Do you think a Medicare model of some sort where Medicare would pay for? I mean, there's care management codes and things that reimburse at very low rates, in my opinion. But do you think there's potential for a larger national model that could support something like this? I don't. Maybe
no, I think their
appetite for that, but
I think their efforts for it. I think like the capable, the Saha, some of them are Medicare, like in the CMS Innovation Center's pilot programs. And so there is room for expansion. I think there are talks about not making, but having Medicare Advantage plans do some of this. Because, but every time we talk about
it's tricky. Like, for example, in HUD, they've eliminated 40% of their positions across the country. So when you take that many people out of HUD, everything gets slowed down. It's a harder system to navigate. But potentially, with the new administration or with more focus on the needs of the seniors and just people in general, Medicare and Medicaid, there are a lot of positives to the program. It's just infusing them with more dollars.
This is kind of out in left field, but I was shocked by the price point of Kavod, even with the subsidy. So affordable, which makes me wonder about all of the other independent assisted transition care facilities. They are either operating very inefficiently or they're making a ton of money.
Or both.
Do you have an impression of what kind of the general gestalt is about what's going on with assisted care?
I've always been involved with nonprofit organizations. Nonprofits always take the money and they put it back in. And then nonprofits reach out to foundations and things. For-profit, I don't have problems with for-profits, but there is some money that's going to go to the investors or the venture capitalists. So when you pull that money out, you end up charging more in order to make, a reasonable profit. So I'd say you should all get involved with nonprofit organizations.
Well, just to follow on that, for those of you who are considering doing a demonstration or research, Michael has been a dream to work with because there's not a huge corporate structure. We have other examples where we spend a lot of time with the corporate structure and only to get defeated. And Michael's like, yep, let's do it. Let's do it. And the connection to Capable is, the history of Capable is a nurse who was doing home visits and said, wow, we need to do something. And she did just like 40 some residents in Baltimore, and then it expanded to this national program that's now potentially going to be incorporated into Medicare. So I just encourage you, if you have some brilliant idea, there's your partner.
Yeah. Something that stood out on one of your overview slides that wasn't mentioned was staff tenure. I think said 6.5 years. And comparing that to facilities where we see 100% turnover in a year. I mean, it sounds lovely, so who wouldn't want to work here? But is there data on why people stay or what drives that?
We pay good, we pay well. Employees get 100% of their health insurance we cover. It's small. I think we listen to what staff want. I think Mandy's, how long have you been with us?
10 years.
Mandy's 10, I've been 15. We have cooks that have been with us 30 years. Again, I think you create a culture, and if you create the right culture. But on the other side, nursing homes, for example, they're so intense. And they do go through lots of staff, and even with Kavod, we have to use some external staff at times. It's just tough, So yeah, I think we once a month we do some kind of food event with our staff. Next week we have a white elephant exchange. Just the basic things that we do to keep people happy.
I'm going to follow up on Carrie's comment about partnering. So there's a lot of researchers here. And so can you talk to us about what partnering with Kavod means, from designing the program to writing the grant to, are we directing indirect costs to Kavod? Just like a broad overview of what it looks like to partner so that the researchers here are aware.
I'm not sure how to answer that.
It's living, it's living lab probably. Yeah. So we have, this example at Balfour right now where we have an MOU, which is what we'll hope to do with Michael. And there's an understanding that we've got, the ability to go there and pitch ideas. Ideally, we'll have a resident council that hears the research ideas and says, yes, this is a good plan for our community, and kind of vets things so that it's a good fit. And staff, of course, are involved with that. And then, of course, you have to do all your regulatory things. But then ideally, like in our Falls implementation grant right now, they get a stipend for participating. And it's a great partnership in that way too, because you heard they have to raise $500,000 a year to do what they do. So that can certainly be helpful.
Yeah, I think we're open for conversation. We have to, I always say you have to kiss a lot of frogs. We go through a lot of partners that never become partners because along the way we can't figure things out, but we'd be open to having these discussions.
Yeah.